everyone. I am going to jump in and get started because we have a lot to cover today. So welcome to Superior Health Fundamentals for a Culture of Continuous Improvement Teleecho. My name is Elena Smith and I'm a Quality Improvement Advisor for Superior Health Quality Alliance. Some quick announcements. We are still looking for future case presenters. If you are interested in presenting a case during a future call, feel free to reach out to me at esmith@mpro.org and I can walk you through the process. There's not a specific thing that you need to present that on, kind of just gaining some insight from others on how to improve quality on some of the things that you might be doing, or maybe you have something that's working really well that you want to share. So today's agenda will include participant introductions. We might kind of speed that along this week just because we do have a lot to cover. We'll then have a didactic presentation on choosing your team, committed staff and teamwork by Barb Link. And then our case presentation will be by Kim Jamaro from Beaumont Health Senior Services. So just as some quick reminders, all sessions will be recorded. We would love to see you. So if you do have access to a camera on the computer you're using, please feel free to turn that on. We ask that everyone makes a practice of entering your name and your organization into the chat box when you join the session so that we can record our attendance. So if you want to go ahead and do that right now, if there are others in the room with you, feel free to type their names into that chat as well so we can kind of get an idea of who we're reaching today. It is also helpful to us if you revise how you're identified in the video gallery by clicking on the 3 dots in the upper right-hand corner of your thumbnail and then clicking rename, and then you can type in your name or the name of your organization. We also just learned that if you are joining us via iPad, that option should be available in the participants section of the icons. We also want to remind you to mute yourself when you are not speaking and to remember to unmute yourself and state your name when participating. If you do want to participate or you have a comment to make and someone else is speaking, feel free to write in the chat box and we'll make sure to call on you next. Just as a reminder, please do not disclose any personal health information during our discussions. And if you're having any trouble with Zoom, you can feel free to message me using the chat box. But if you have any other questions or comments, you can message Barb. Maybe it's saying you want to do a future case presentation or something like that. Please help us foster a positive learning environment when asking questions and making comments. And remember that we're all here to learn from each other. So rather than go through everyone that's on the call today, I just wanted to see if there's anybody that didn't join us last week that's joining us for the first time this week. Are there anyone that meets that criteria? Joanne, do you want to introduce yourself, Joanne? Let us know who you are, what your organization is, and what your title is.
Hi, good morning, everybody. My name is Joanne Sandvik, and I'm with the La Crosse Medical Health Science Consortium, which is located in La Crosse, Wisconsin. And the consortium is actually a collaboration between our 2 hospitals, Mayo and Gunderson, and our 3 higher ed institutions in La Crosse. And I do a lot of collaborative work as a project manager with all those organizations, working on clinical sites and different things like that. So I'm really joining this as a learning opportunity for myself versus having my own continuous improvement case. There's just 2 of us in our office. But I thought this would be really helpful for me to learn as our hospitals and things always are talking about this process, that I have a better understanding. Thank you.
Great, welcome, Joanne. Happy to have you here today. Is there anyone else that hasn't joined us in last week's session? You can feel free to unmute yourself if you didn't join last week and you'd like to introduce yourself to the group this week. One of the benefits of the Echo is that we kind of follow up each week. So it's nice to kind of get to know each other, see who's all in the room with us, and learn from each other. We'll give it just a couple more seconds if there is anyone that didn't join last week that wanted to introduce themselves today.
Hi, I'm Linnea Hinker, and I'm the Quality and Patient Safety Manager at North Memorial Health Hospital in Robbinsdale, Minnesota, and I was not able to join last week.
Welcome. Well, thanks for joining us this week. We look forward to having you. And I think If there's nobody else, I'll give it just a couple more seconds and then we will move on to our didactic presentation. Okay, well, with that, I am going to hand it over to Barb and I'll let her do an introduction and talk about her didactic presentation on choosing your team. So thank you everyone for joining us today.
Thank you so much, Elena. All right, I will now share my screen. Just take a minute here. Okay, just a quick check. Everyone seeing my title slide there? Okay, great.
Yes.
Thanks, everyone. So this second didactic presentation builds off of the first one that I talked about last week about quality leadership in a quality improvement team. This one is then moving into the next stage of choosing your team, committed staff, and teamwork. So today's learning objectives will be to define team member roles for a successful QI project, learn the stages that teams go through, and then talking about a living team charter that defines goals, roles, and outcomes. I'll also touch on team involvement during COVID-19 as well. So an important part of choosing your team members is first, even before you start to choose your team members, it's important to think about your quality improvement project and its specific aim or goal that it is trying to achieve. It's important to get the right team members to the table right off the bat. And when you think about a quality improvement initiative, it's really important to think about not only composition of your team members, but the size of your team. Really, it's important to think about a various group of people that are wanting to achieve the same goal or aim at your organization, but you don't want that team to get too big. You don't want it to be too small. You want it to be about 5 to 8 members. That seems to be the ideal size for really getting an initiative to move forward. So when you're thinking about the specific roles that you have within a quality improvement initiative, there are some specific definitions of those members. Now, this is a perfect world. You can't always have these definitions, but when you're thinking about it, I think it's very important to think of these sort of definitions of different roles that you want on your team. So the sponsor is a specific role that actually isn't a team member specifically, but it's someone in administration at your organization who's in a position that can really support your team and its goals, feels that it is an important project to work on, can maybe give different team members time away from their regular duties to attend team meetings and work on the goal. And then also is a leader in performance that can provide guidance when needed for the team. The facilitator is also not a specific team member. Maybe sometimes the sponsor has some of these roles as well that moves the team along. It's not necessarily, well, it is separate. It's not necessarily vested in the outcome of the team, but it has the background and knowledge that can help the team to move along, maybe a quality improvement person at your organization who can provide concepts and information, tools to move the project along. Then now we're moving into the actual roles in the team. A leader, there can be a leader who's on a daily basis, just attends meetings, but that leader is really invested in the outcome of the quality improvement initiative and really is guiding the whole group along to achieve the goal. Then you have a champion, and that person usually is a leader who provides project credibility and is integral to the social structure. They really within the team and outside the team, really champion what the goal is and can communicate that to everyone within the organization. Sometimes you don't always have the ability to have technical expertise. This is specifically an analytics person who knows the subject intimately and can provide and understand processes and measurements. When you're gathering data, they can interpret it. We at Superior Health have a great analytics team that's always constantly analyzing our data and providing input, can communicate that into a variety of education levels when we're talking about analytics. They're really great. But if you don't have that access, in future sessions, Elena will be providing some tools and tips on how to do some data analysis within your quality improvement project that might not have to need that technical expertise that you can do as well. And then we're talking about just your general member, vested in the outcome. They have a specific area of expertise that brings to the table information and knowledge within their specific professional expertise that helps to address the issue of the quality improvement project and can help move it along. You might have one or two of those members. And then of course, you always need a timekeeper and scribe. Maybe other members might do that on a rotating basis. Or you could have a specific person assigned to that for every meeting. Now then, moving back to my example at the beginning, this is an exact example of what an aim would be and who those team members might be for this specific quality improvement project. So their aim on this group is that they'll improve care for all patients with chronic disease, make improvements in our clinic that impact the 6 dimensions of quality as outlined in the Institute of Medicine's report. And there's a hyperlink there if you want to learn more about that. So they have their aim right up in front. And then the different members. The technical expert is a physician from the downtown clinic that's going to be implementing the quality improvement project, a day-to-day leader, which is a nurse manager at that clinic. And then additional team members are shown here: patient educator, medical assistant, scheduler, lab manager, quality expert. And then you've got your sponsor, and that's the medical director for all of primary care within that organization. So just an example of how this particular team formed AIM and then team members. So I wanted to also talk briefly about how teams develop. Typically there are 4 stages. Teams can go in and out of them. Maybe they might skip one depending on if they've worked on other projects together. If team members join or move, you might end up starting back at the beginning. But especially as a leader of a quality improvement project, it's important to sort of know these phases, because all of a sudden, if you're stuck in a phase, you might go, oh, wait a minute, that's why this is going on. And it provides some insight as to why things are moving along or might not be moving along in your quality improvement project. So typically, again, might go back and forth, might skip a few, but these are in general what most teams go through. And it's interesting when you take a step back and think of most of teams that you're on, even outside of quality improvement, you kind of see these things occur. So you have your forming stage. That's where members are getting to know one another. You have to agree on your goals and vision for the task at hand. And then you're delegating the tasks as a leader. Then you have a storming phase. This is where people are kind of starting to feel a little more comfortable with each other. They might express their individuality and almost resist the group influence at this phase. As a leader, you need to pay attention to this. You can get stuck. People can get stuck in circles of communication. People aren't moving along with action items. They're really just kind of digging in on their objectives. You need to be supportive at that point, call it out, talk it through, so you can get to the next stage of the norming. And that's when the groups are developing more close ties. They're developing a little bit more of a team identity at this point. And they're feeling more comfortable having that definition that I talked about last time about constructive conflict, where they might be having conflict, but they can discuss it and come to a productive resolution of it. And then the last stage is that performing. Team, they're working harmoniously, and they're working towards a goal, and they're being very productive. And at this point, that's where the leader can kind of take a step back, and they don't have to be so hierarchical and delegating things. People are just organically stepping up to the plate saying, oh, I feel very comfortable taking that on, I'll do that. And then another person will say, oh, that sounds good, and I agree with this, I'll do that. So it becomes very organic and very harmonious at that stage 4. You really can feel that within the group. So it's really important to look at these developmental issues and look at them from a leader perspective as well. And these are just some characteristics of an effective team. Everybody's contributing, there's clear goals, lots of commitment, regular attendance. You know, when people don't attend, you have to revisit things constantly and you don't get moving along. There's a very collaborative and cohesive environment. You feel that there's a non-hierarchical structure in place. I also wanted to just touch on developing a solid team charter. I will be honest, I have been involved in development of team charters in the past, and they felt like almost a root canal. We've spent a lot of time on almost minutia and getting things down on paper and what are our goals and debating what the goals were. And then we never revisited or looked back at it. And then it became old and you needed to dust it off and nobody wanted to go back to that thing because it was so painful in the beginning. But if you develop a really solid living document of a team charter, I think it can really eliminate duplication of efforts and waste of time. Put some work in up front, revisit it frequently, make it very relevant for your attendees. I think it can be very beneficial to the team. I really like some of the definitions on this particular slide of a team charter, and I really just wanted to highlight some unique things about really talking about people's area of skill and what their work skills are and how they tend to work. You may have a very action-oriented person on your team, and you may have an observer. An observer might have to process information, might come back with some great insight at the next meeting, but in that specific meeting might not talk a whole lot. And then you might have a person who's very action-oriented, always speaking out, feels very comfortable, wants tasks done. Both of those skills are really needed on your team, but you need to understand those different individuals and how they work and maybe get that down on paper in your charter. So really you're using all the assets of your team fully. So just some suggestions. And also I just wanted to visit some tips on working in a team environment during COVID again. This is from a Cleveland Clinic article that I have cited at the end of the slides in my resources. Great article, really very helpful. Just some things looking at your quality improvement team and how it might have to change within real time during COVID-19 or any type of crisis your organization may have. So you need to look at your quality improvement committee. If it was meeting monthly or quarterly, might even have to meet weekly, daily in COVID pandemic sort of environment. Look at the frequency of meetings because things are constantly changing. Measuring data, it's important. I know we have some data analytics that we're asking for people and they're like, we just can't do it right now. Try and make it simple, easy for people, but you still need to do that. Policy and procedure changes, things change rapidly. You need to have real time, and Kim's going to talk about some things about this today too, I thought that were really great. When you need to have access to information quickly for your particular department, in a quality improvement environment, make it easy for your staff. Make one click to get to what they need. Have it on a website that everybody can get to. Don't have long documents that they have to cipher through and click, click, click multiple times to get the urgent information they need. And keep up with national guidelines and recommendations. But more details are in that article. I've got it cited. It's a great article. I really just want to click to it quickly. I do have some of those resources here for you to access, and I'd strongly encourage you to follow up and take a look at some of those as well. And I can tell there's a little bit of delay. I hope everybody got all that. Any questions? Now I went a little quickly, but I want to get to our case presentation today too. If anybody has any questions about the content, always can chat them in or email Elena or I afterwards, and we're happy to address those as well. Okay.
Thanks, Barb. If you want to start pulling up Kim's presentation, I will do a quick introduction. So now we are moving on to our case presentation. So I know last week we shared our case presentation on just a form, but case presentations can come in a lot of different ways. So this is kind of an alternative to that. We are definitely open to whatever you kind of want to present on future sessions. So today we are going to hear from Kim Jamaro. She's the Quality Improvement Specialist for Beaumont Health Senior Services. So Barb is going to be pulling up her presentation. And if at the end of this, we will have that discussion again. If you are joined by phone, you can unmute yourself by pressing *6 if you want to join in on that discussion later. And again, if you are joined via computer, you will be able to unmute yourself right on your screen. So with that, I am going to hand it over to him. Thank you.
I was just getting a little whirring of my computer's fan, so I tried to call in, but I'll leave it on this and hope it's not distracting. We also have Julie Castley, the administrator at Beaumont Rehab and Continuing Care, on with us. She is part of the architect of this plan and certainly the driver of it. So we're happy to share with you how our QAPI plan came to life during the pandemic. Next slide. So we want to cover today phases of our QAPI plan in a pandemic. So first was the overrun phase. That was the spring, probably through April and May, QAPI and the first COVID surge. Then we reached a new plateau. So we were not done with COVID, but kind of in between surges. Right now, we feel we're equipped to succeed as we move into the second COVID surge, and we're going to talk a little bit about our process for planning and achieving improvement. Next slide. So here we go right into the first surge. Next slide. In the first surge, I'm sure our experience was not unique. All of a sudden, as part of our improvement work, we found leaders serving in frontline roles related to COVID impact on staff. Mission critical tasks, highly focused on PPE and infection control training. And then those new tasks, you know, we're always busy every day trying to perform the best patient care and check on it and talk with our residents. And all of a sudden we were responsible for COVID screening, a rather robust process, additional reporting, regulatory and CDC updates. As Barb mentioned, those came, seems like daily in the late March through May timeframe, and then trying to stay on top of a PPE burn rate. Obviously, PPE was a mission critical task, and how fast we went through it and whether we had enough became urgent to stay on top of. Next slide. So in terms of our improvement program, we wanted to COVID screen our program. We needed to check, because when it was overrun by the first, you know, everything that exploded in the beginning, it all seemed to come at us at once. And we're sure our improvement plans kind of had shortness of breath and fatigue and nausea, vomiting. We needed to kind of settle it down and say, we can still do this. The question is how. So we decided to focus on critically necessary information and making critically necessary decisions. Next slide. And the way we did that in the first surge is we took a hard look at our QAPI agenda, because our frontline staff and our leaders who would normally report something to the QAPI committee when it met, all of a sudden didn't have time to do reports. They were actively involved in patient care. So we needed to make that meeting useful by making sure we could feed into it. And what we fed into it for April and May, when we were in the height of it, was Emergency Operations Center highlights, emergency orders that the governor had issued, that MDHHS had issued, Regulatory updates and guidance. CDC and CMS especially published all kinds of revisions. It seemed like every day, right on top of each other. And the unique thing about bringing this to the QA committee in a presentation format is that we actually included the link for the guidance. And then we had time to ask the question, because at the end of the day, we were still a QAPI committee responsible for improvement. We wanted to know where the holes were with compliance. You know, do you have enough staff? Do you have the resources? What else do you need to help with compliance with this particular regulatory guidance emergency order update? Then we reviewed Section 1135 waivers, because while those are in place for the emergency order for the pandemic, they are not everlasting typically. So we wanted to familiarize ourselves with those and understand the latitudes that gave us during the height of the pandemic. And then we actually began to start to do the stretch discussion about COVID recovery, because we were sure that there was going to be a plateau between the first and the second curve. And we wanted to make sure that we had line of sight on getting out of the hysteria of everything that had hit us initially all at once. Next slide. So let's talk about being in that plateau we talked about. Next slide. This is the section of time where our leaders could pause for just a minute. Our staff that had been off for COVID started returning and working again. Leaders had a minute to assess the impact, right? We had residents recovering, residents needing restorative services. We needed those in place and continuing. And then we also needed to take the facility assessment and update it. So we had some shifts in our census and in our population mix, and our facility assessment needed to be reevaluated to make sure we were stacking the right resources on top of that resident population. Next slide. So key for that time period over the past summer, again, updating the facility assessment, doing a mini after action plan. So we had a sense that we were in this plateau, but we also believed we were going to go around the block again on another surge. So we wanted to pause and just say, if we could do it over, you know, if someone had called last July and said, hey, I'm going to send you an epidemic in March, what is it that we would have made sure to have in place or have at the ready? We just a little mini after action plan, reassess again critically necessary information. We had more breathing room in this space. So maybe we didn't need to continually dedicate our entire QAPI meeting to a review of the current regulation and guidance updates. Maybe we could actually start to take in the information coming from the leader assessment of the impact and our resident status, and then reassess what critical decisions needed to be made at that level. Next slide. Julie Castley, the administrator there, developed a tiered approach to handling our improvement efforts at the site. And this did a couple of things. It allowed a time focus that played to the limited resources that we had at the site. And it also gave the monthly QAPI committee meeting time to process. So we start with the daily QAPI meetings. This is a clinical meeting, review of the 24-hour report, falls, wounds, weights, behaviors, other risk areas, talking about immediate action plans, resident by resident. That rolls up then to a weekly QAPI meeting where we're looking at intervention effectiveness. So if Mrs. Roberts fell on Monday and you put actions in place and updated the interventions, how's she doing? You know, were they effective? And then rolling into the monthly meeting where we're taking the combination of things that are trending in weekly QAPI and saying, how is that impacting a measure perhaps that we're following, or a process that we're trying to fix and put some things in place. And then really talking about getting good at root cause analysis and action plans. Next slide. So now we're in the second surge. We've breathed some life into our QAPI program again, and here's how we're moving forward with it. Next slide. So now we're making every effort to focus our QAPI efforts. So as you saw when we covered the 3-tier approach, decisions that are needed immediately are turfed to that daily or weekly QAPI meeting. That's much more timely than having them wait for the monthly QAPI meeting. All staff are involved in improvement efforts at this point, and we have an education plan that's supporting that. And still everything else in the yellow and the red is happening. But at this point, those have kind of become routine processes. And we feel with the 3-tier approach for QAPI, we might actually start to get to some of the things Barb talked about, initiating teams and actually getting a project rolling. Next slide. So in the second surge, we evaluated the program itself. We recently made use of the QAPI Self-Assessment. That's a CMS tool. If you Google CMS QAPI resources, we actively use that. Developed a continuing education program, again, supporting really strong root cause and action plans, and then focus reporting to the right tier. So we're ensuring decisions are made when needed. Next slide. This is that self-assessment, and we've had as a site with our leadership team conversation about how do we chunk down the items that a QAPI plan is supposed to cover and make those items that we can actually action in a reasonable time frame. So we've handled number 1 in the orange. We are in the middle of the green items doing leader education for reporting that's coming to our monthly QA meeting. Really getting leaders to look at system and process breakdown and linking those corrective actions to that. And we're going to show you today a process for doing that. The yellow items are on target to follow that green education. And then the items Barb was talking about really get into the blue areas. So that's the next place we're going, you know, as we get along this journey. Next slide. Did your screen stick, Barb? There we go. Okay, so let's talk about planning improvement. Next one. So to support that tiered QAPI approach and support our monthly committee work and responsibility, we're encouraging our leaders to go see. We need their feet in the processes that we're trying to improve. They need to be right there with frontline workers, and we're going to talk about how they do that. Then we're going to talk about root cause analysis, risk reduction, and the ever important evaluation, because you can't just set an action plan without doing the full PDCA cycle and going back and checking to make sure it's working. Next slide. There we go. So let's talk about the go see. Systems that rely on perfect performance by individuals to prevent errors are doomed to fail. That's one premise that we believe. So when we send you for a go see, you can expect some perfect performance to not be looking so perfect. Next slide. These are things that might not look so perfect, and yet we found that they rely on perfect performance. So water being passed within 4 hours of a starter shift, every caregiver referring to that care guide before transferring a resident, meal trays, making sure those are accurate, linens being available when needed, weights taken as ordered, non-functioning equipment being reported. Those are things that at surface level seem to rely on perfect performance. And yet if we don't go see, we may not find a problem that may develop in one of these areas. Next slide. We may find human error. We may find at-risk behavior, and we may find truly reckless behavior. And we need to get behind the human error and the at-risk behavior and see how we can impact that. Next slide. So when we ask our leaders to go see, we want them to focus on a particular process. There are 10 or 15 care processes that go on a unit in your skilled nursing center at, during any given shift. But if you're going to go see, you want to focus on a particular process that's having a problem. Start at one end and walk to the other, engage the people touching the process at each end of it. Ask why. You need to be a really good listener and verify with observation. Show respect and then use data coupled with that observation to make your assessment. Next slide. More eyes on a process is better. So when you do your go see, what you're expecting to see is your staff understanding a process or a procedure that has some clear steps to it, right? Do this first, this next, do this last. But if you're truly engaged, listening, asking, next slide, this is what that process at times will look like to your staff. So you may find they're going to start doing this first, and before they can do this next, somebody taps on their shoulder and they're off on another do this first. Or they may go between do this last, do this next. Maybe they're waiting for supplies. Maybe they need that second staff member. What is it that is running them around this process circle so it doesn't look as clean as we expected? We are responsible for removing those barriers. Next. So root cause analysis. Now that you've gone out there, you've talked to your staff, and you have all the information that you need to make an assessment of where those problem areas might be. This is the root cause statement that we ask our leaders to try to work with. It really keeps us from trying to solve problems that are really outcomes, because that won't be effective. So we use a statement that reads something, which is the cause, led to something, which is the effect, which increased the likelihood of something, which is the outcome. Next slide. And the important thing about that statement is that you must clearly show cause and effect relationship. You have to use specific and accurate descriptors for what occurred. So you can't be vague, you can't be general, you can't assume somebody didn't feel like doing something, because human errors must have a preceding cause. Something else is driving that. And violations of procedure, as with the staff in the circle, violations of procedure are not root causes, but must have a preceding cause. And failure to act is only a causal factor when there's a pre-existing duty to act. So those statements need to be really solid to get through our QAPI committee. Next slide. This is another way we explain it to our employees. So, which increased the likelihood of something, that's really what we're looking at out the rear view mirror, right? We've already driven down the road, the resident's already fallen, the linens are already empty in the linen closet, whatever that situation is, it's already happened. It's behind you in the rearview mirror. Something in front of what needed to happen that day occurred, which led to a problem getting on the bus, right? And the outcome is what you're seeing in the rearview mirror. So we really stress that you need to get out in front of a problem and try to get ahead of it. You need predictive data. Next slide. This is one example of how that statement might lay out in a situation. So we experienced fewer applicants during the pandemic. Obviously, we're running, crazy trying to keep, our resident care going and sufficiently staffed, but we wanted to do some recruiting at the same time. So applicants without access to a computer during a pandemic, that led to our applicants not being resourced to reach a website to complete their application. So we had fewer of them. As we met through the weeks talking about recruitment, we discovered that the applicants that we had, many of them didn't have home computers. which we may not have realized previously because non-pandemic, they would have come in and used a kiosk to do that, right? Or I don't know, but we actually also found out that many of them may have used a computer at the local library. And for a while, the libraries were shut down. So now we had someone that only had access to a mobile device to apply, and we didn't have a mobile application. So we needed to resolve that. Next slide.
I might have to reshare. I'm not sure.
Oh, I can't hear you, Barb.
Oops. Something. Can you hear me now? No.
All right. In the interest of the recording, I think I'm going to try and move forward from my slide deck in a minute here if we can't catch up. There we go. Okay, next slide.
Still not going. Let's see.
Well, our next example, virtual education for school-age children. All of our sites were impacted by that. And that was really leading to potential applicants needing to stay at home to supervise learning, which also led to fewer applicants. So we needed to look at some policy flexibility for parents that needed to be home doing that supervision so that we were able to accommodate them. And again, we talked about data and the importance of data being in front of the bus. So your data should ideally precede the problem. Your data, there we go. Your data, it needs to be easy to access, timely, actionable, and succinct. It needs to push. You need to push. Items needing improvement need to be pushed to the accountable person. So when Barb talked about engaging frontline staff, this is exactly where we're going with this statement. Leading indicators, windshield indicators can get tracked in real time by frontline teams to measure improvement themselves. Static or point in time and dynamic data over time periods should be combined to provide a full picture. So as we do the roll up to the monthly meeting, we're always looking at where are those measures trending. But always try to use windshield data rather than retrospective data. Next slide. Now we're going to show you what we do with our action plans. And the important thing is that we want to make the correct thing the easy thing to do. Next slide. There we go. If the correct thing to do is complicated, there's a better chance that your process is going to have an issue. Next slide. So this is what we use as a measuring stick for action plans in Beaumont Health. It's called an error reduction strategy. And it's scored 1 through 9, the values 1 through 3 being at the lower effectiveness, involving a whole lot more human vigilance. So this is going to be your unit managers doing audits, right? This is going to be education that's being conducted again and again. Next slide. We'll run through these. So areas 1 through 3, suggestions to be more careful or vigilant, education and information, rules and policies. These are typically things that get our plans of correction passed, right? When we have citations. So remember we talked about vague statements for root cause. There's also vague action plans. A staff member being counseled, nursing staff were in service, policies reviewed, information available, and you still haven't decided that education was the problem to begin with. right? The education may support something that you determined was a root cause, but in and of itself, it should not be your solution. Next slide. Now we're getting up to the mid-range of action plan strength. This is where we're talking about standardization, redundancy, reminders, and checklists. And if you think about it, our education is typically talking about some standardized process that we want our staff to absorb and perform. So controlled medication management, you've got both nurses involved, oncoming and offgoing, physician orders and care guides, those are redundancies. Life safety matrix, our facilities person keeps an entire matrix of facilities, equipment, and systems and related check dates and uses that as a checklist to monitor and make sure that systems are checked when they're supposed to so they work when they need to. And the COVID-19 screening questions, that was standardized as process. Where your action plans really get traction on the road is on the next slide. If you can get your staff to push those action plans into automation and computerization, forced functions, or fail-safe and constraints, now you're talking about plans where you're no longer getting cited, you're not causing harm, and your operation is going along quite smoothly. So establishing one entrance for a COVID entrance, that was kind of a forced function. There's no other way to get in and you're gonna go by the screener. Clinical dashboards, computerization tend to cover that. They will alert the nurse as the end of the med pass timeframe is coming up. And then the one we're familiar with in skilled nursing, employed staff time extract is an upload for payroll-based journals. So something that's automated so we don't have to touch it, less opportunity for error. Next slide. So we ask that our leaders apply error reduction strategies to root cause. So what we typically found at the beginning was that education policies and reminders were relied upon. We had some complex processes which increased the likelihood of errors, and proper procedures may not have been intuitive. Again, remember, we have to make the right thing to do the easy thing to do. So next slide. What we ask our leaders to do is to choose error reduction strategies in the yellow or green strength and aim that at the first something, the cause of the issue. Next slide. So in summary, on the risk reduction area, find the right data to monitor a process. Look out the windshield, see if you can capture something in real time to alert you that something may happen instead of something in the rearview mirror. Use the root cause statement, set strong action plans, aim for yellow or green, make the correct thing to do, the easy thing to do, and go see. The go see is your evaluation of your action plans. So we actually don't allow our managers to list and audit as an action. It's a go see activity. You're actually going to go check and see how those action plans are doing and whether they need to be adjusted. Next section. So adverse events, as we heard, we are responsible right now for covering adverse events and COVID related infection control items. So I just wanted to touch on this briefly. Next slide. Beaumont has a system where items that qualify as a sentinel event are bubbled up to a system-wide meeting. And that meeting will confirm at what level those events will have root cause analysis done. High priority review is a serious event, not quite sentinel, but it still will get that formal root cause analysis. Next slide. Then we have department reviews. So those are things that occurred within a single department, don't affect other disciplines or other areas in the system. They'll allow us to handle that on our own site. The site itself will do a sentinel event review, and then the sites have ongoing quality monitoring. So anything that falls into a sentinel event or an almost sentinel event, a near miss, we'll end up with quality monitoring to the local committee at the 30, 60, 90-day mark. So next slide. For this process, we start with contributing factors, and that's one of the handouts that you'll receive with today's slide deck. That in-depth root cause analysis covers every single one of those contributing factors to leave no stone unturned. And then again, we move through the root cause analysis, risk reduction, and the go-see to circle back and check the effectiveness. So in summary, next slide, your QAPI program, it has to make the correct thing to do the easy thing. What needs to happen needs to be intuitive so it happens every time. Your program itself has to be able to breathe. Those of you on the call that are administrators or in your facility leadership, that program, if it sits on a piece of paper in a file drawer, isn't going to cut it. You have the latitude to rewrite it the way you need to make sure it's always a relevant document and process. Resource it in a supportable format. So as you saw moving forward through the second phase, we're using a 3-tiered approach because we don't want to have the big bathtub of a monthly meeting where we're tying up people's time writing reports and, you know, spending 2 hours talking about things. We connected our tiered approach to how quickly decisions need to be made. And then direct resources to eliminate adverse events and generate improved care and outcomes. So that's how we do it at Beaumont. I'd be happy to take questions on it. And I'm sure Barb would be happy to take questions again on her presentation. And Julie Casley, our administrator, is also on the call. So if you have questions of Julie, she'd be happy to answer those also.
Thank you so much, Kim. Yes, so we will take some questions now. If you have any questions about the process or anything like that, feel free to ask those right now. Again, if you are joined by phone, you can press *6 and unmute yourself.
Apparently I can't hear anyone, so I'm going to plug in my headphones. Okay.
Sounds good. I don't know, there might have been something weird happening in Metro Detroit area because I lost my internet in the middle of your presentation and got back on eventually. So thank you for waiting out those technical difficulties. But yeah, if you have any questions, feel free to unmute yourself or add them to the chat and we can read them aloud. And just for some extra just so you know that Beaumont Health is located in the Metro Detroit area.
If we have other sites on the call, other skilled nursing sites, I'd be interested if and how their QAPI approach may have changed through the different phases of the pandemic.
Anyone have any feedback on that question? Anyone want to share just what their processes looked like during the pandemic?
So Kim, can you hear me?
Yes, I can.
Okay. Well, I just had a general question. I'm just wondering, was there in any of your processes or ways that you wanted to do things that you had any pushback from leadership or anything that you had to do or ways that you felt that you communicated to your leadership that made it more seamless? Or is that your culture there? Just some sort of dynamics around that. I was just curious.
I think Beaumont has the larger vision of a quality culture, and we're working at our sites to get that implemented. What we did find was we needed to change up how our education was offered. So, you know, during that plateau period and the first part, you know, right before the second surge, we offered lunch and learn to our leaders. We pulled them, you know, into an area and offered virtual education, 30 minutes in total. So we had to break it down to little snippets. You know, what you saw as 6 slides on root cause, we made 30 minutes of, you know, an in-depth discussion, and then Julie facilitated like a real-time, you know, Q&A after with the leaders to see, well, okay, if that's it, then, you know, how do I put it into practice? And we had that timed so that they had a tool that they received if they received the, you know, the QAPI report or received the root cause analysis guide. They had something they left with that they could take and apply right away. And then when we had our first meetings out of the chute after this education, we color coded their action plans to the risk reduction strategy. So we want them to kind of internalize, are my actions red, yellow, or green? So they really start to make that stretch.
Okay.
Were there any strategies that people took away from that they now want to implement in what they're going to be doing?
I don't think so. This is Julie. I think it really just created teamwork from everything that we had been through with the COVID. So really the foundation, you know, we started some of this pre-COVID and then kind of had to work through the pandemic as a team. And that really kind of solidified the team as to, you know, kind of committed to getting back to ordinary process improvement just for improvement's sake. So, you know, they probably, if you ask them now, they would think it was all their idea to do it this way and have the daily meetings and the weekly meetings and reporting up to QA and so on, which is as it should be, right?
Mm-hmm. That's great. Thanks, Julie. I do just want to remind everyone on how to unmute. If you are joined by phone, you can press *6. If you're joined on the Zoom platform on your computer, down in the lower left-hand corner, you can click on that microphone and unmute yourself. I do know we are at the top of the hour, so I do want to be conscious of everyone's time. So thank you so much, Kim and Julie, for your presentation today. We hope to have some more case presentations in the next coming weeks. If any of you are willing to present something, maybe it's just like what your plan is for vaccinations for your staff and you're not ready to do it, but you have some plan in place and you want to get feedback from what other people are doing, anything like that. Please let us know. Again, my email address is esmith@mpro.org. You can feel free to email me and I can walk you through the process and help out with that. But again, we definitely want to hear back from you guys on your case presentation. So we welcome those in the next coming weeks, and hopefully we will have one by next session. So thanks again, everyone, for coming to today's session. Next week, December 15th, same time, 11 Eastern, 10 Central. And the topic is going to be on, Barb, remind me of your topic again.
It's communication within your team and including the patient voice as well.
Thank you so much, Barb, and we will see you all next week. Thanks so much.
And thank you, Kim and Julie, so much for your presentation today. I think there's a lot of quality information that could transfer to any setting. Thank you.
You're welcome.
Absolutely. We'll make sure that everyone gets your presentation and your resources.